I'm Heidi Smith. I am hosting this. I also work for Health Insight. I'm the project manager of the Beacon Project, which is what you're here to hear about today. Actually, it's what you heard about yesterday too. For those people who weren't with us yesterday, everything is sequential. So we started yesterday with some people who presented the federal agenda, the reasons behind healthcare reform, a lot of good data and statistics. Sorry you missed it. We are recording, which is why we have our Nick over here, our sound engineer. We're not recording you all, and we're not videoing, but the voiceover goes with the slides. So if there's something from yesterday, we'll probably have some. I know we'll have all of this available. Whether or not we'll have it all on our website at healthinsight.org, I don't know, but it will. The slides themselves will be available if you're interested. So we started with sort of the political environment, and then we got local, and we talked about the HIT environment. And then we talked about the problems with the data, trying to get good, reliable data, because this whole project was driven on data. Although initially, we just kind of went with what we had. And at the end, we talked about the end-of-life project, the ePulse, which didn't. The Beacon Project has a couple of different focuses. Mainly it's on diabetes, improving outcomes, improving care in the community. But then we have this one little side project that has gotten really quite big about end of life. So won't hear about that today. Mainly we're going to focus on primary care, what's going on in the clinical environment, and how we have facilitated, at Health Insight, working with the community, have facilitated change to improve care for diabetes in our community. So our first speaker today is Dr. David Masihdas, and he's not with Health Insight, but he's throughout this project. Dr. Masihdas completed his optometry training at the University of Houston in 1981. He started his medical eye care practice in Salt Lake City. Right after that, he provides diabetic eye care services for the health clinics in Salt Lake City. He was involved in numerous research projects related to diabetes. He's past president of the UOA and the GWCO, which he will explain. Dr. Masihdas has lectured throughout the U.S. on diabetes, dry eye diseases, and neurodegenerative diseases. He's a member of UOA, AOA, and in 2000 he founded the Diabetic Eye Center in Salt Lake City, dedicated to providing comprehensive eye care to patients with diabetes. Dr. Masihdas.
Thank you.
Oh, 1 second. Stephanie, do I have to do disclosures today?
Yes, you have to do that disclosure. You can do it next time.
Okay. Basically, nobody here is benefiting economically from any of the material covered, right?
Yeah.
Yeah. And we'll read the slide.
Yeah, after Dr. Masihdas, then we'll pull the original.
Okay, thanks.
The UOA is the Utah Optometric Association. I've been the president for the Utah Optometric Association. I've been on the board for the National Association. I've also been the president of a regional association which incorporates 11 states in the West. That's what all those acronyms are for. I'm going to try to, this is longer than what the time I have allotted, so I'm going to do what I think is the most important part because I'm also interested to see what questions you may have. Part of the concept here is that we are all involved as providers in different aspects of eye care, of health care for the diabetic patient, and that's what the basis of this is. These are the people who are involved in engagement, in getting the patient to be engaged. First of all, it's the patient. Then we have the disease. We have the physician. We have the care involved, the follow-up care, the support, and what do we expect from the outcomes. Throughout this presentation, I'm going to address each one of these and how they're involved in getting the patients engaged. Getting patients engaged in their treatment, regardless if it's diabetes, high blood pressure, or any type of chronic disease, is critical because as providers, we can only do so much. The rest of it is on the patient's part. So who is the patient now that we're dealing with? This is a patient, if they're type 1, they're typically a child. An adult is type 2. These are patients who may be overweight, who may have a family history of diabetes. They may have poor eating habits, may not be highly motivated. These are some characteristics that we have. They have a sedentary lifestyle. Some of these patients are very fragile. You tell them something and they just totally fall apart, and you have other things to deal with. These are patients basically who need help. Some of them may have knowledge of diabetes. Some of them are afraid of the unknown. Some of these slides, I found it last night, had misspelled words. So they're afraid of diabetes because of what they've heard or what they've seen in those they are acquainted with. A lot of these patients may have vision problems. They may have other types of health problems. They don't understand why they're feeling a certain way. They don't understand why they have this great urge to drink a lot and urinate a lot. So they're generally looking for answers in all different directions. And where do they go first for the answers? The internet. Everyone knows you can put anything on the internet. So what do they listen to or read? All the things that are bad, of which those are typically about 90% of that is misinformation. So as a provider now, you're sitting there with this patient who is basically a train wreck, and you've got to put it back together. And that's basically what we're dealing with. In some of these, in some ethnic cultures, being diabetic is not something they like to talk about. So as a physician, you have to probe. They'll look you straight in the eye and say, do you have a family history of diabetes? No. Anytime they answer quickly like that, you know there probably is something more going on. So you have to also be a little bit of a detective trying to search out who these patients are and what some of their family histories are. And some cultures call it by different names. They don't call it diabetes. They call it something else. So you also have to be very careful because you got to make sure that they understand that you're looking for information. The other thing too is there are some cultures that they don't like their women to see male doctors, so they're very hesitant to give you any type of information. So now you're sitting there with this patient who, like I said, is a total train wreck. So what do? This is the long definition of diabetes. Basically, diabetes is a dysfunction of the body using and utilizing carbohydrates and sugar. It doesn't mean anything to them, but I put that up because this is going to be in a presentation, and I wanted people to understand what diabetes is. Now, this is some demographics about diabetes. This slide, and I'll admit to this slide is about 2 years old, and these numbers have all changed. For instance, it's not on this slide, but this last year, the federal government spent over $254 billion on diabetic care alone. Last year, the year before that, 2011, they spent $174 billion. So you can see the rate it's increasing. There's about 20 million patients who are diagnosed, and this slide says 7 million, but it's about an equal number that is undiagnosed. But the part that is most striking is the one that are pre-diabetic. We'll talk about pre-diabetes in a little bit, but these are the patients who are heading in that direction. And so you've got this great tsunami starting to happen, especially with the baby boomers. Patients who are 60 years and above have about a 25% chance of being diabetic virtually by getting older. That's having no other risk factors. So you can see that with our baby boomer entering our healthcare system now, we're going to have a huge number of these patients that are going to be pre-diabetic and eventually become diabetic. The interesting thing about this slide also, too, it talks about there's 1.9 million cases of diabetes in patients ages 20 and older. And that's a huge number. What this slide doesn't say also, too, is that there's a huge increase in teenage diabetic, primarily due to lifestyle, eating habits, and lack of exercise. This is something that, you know, we have to start looking at an earlier age versus what we used to do before. Now, I'm going to give you a general overview of what there are two types of diabetes, the type 1 and type 2. Type 1 typically is more acute. It's where the pancreas basically has shut down. You don't have any insulin. This represents about 10% of the population of diabetics. Now, you're going to hear things like insulin dependent. You're going to hear juvenile diabetes. It's all the same thing. The new designation for this type of diabetes is T1DM. If you look in any of the literature and you see that designation, that's what this means. It is type 1 diabetes. These patients are typically become very ill in a short time. Now, a lot of times, and I put the last sentence there in terms of eye care because as I'll show you later on, eye problems are one of the critical factors in patients who are diabetics. Oftentimes, these patients, there's not a mad urgency to have their eyes checked right away because we know when the disease started. And when that happens, we can work from there. Now, type 2 diabetes is basically a different animal. It is basically where the patient doesn't have enough insulin to support the body. They basically have either no insulin or little insulin or they're insulin resistant. The biggest concern about these patients is not that they're insulin deficient, is when it started. Oftentimes, and I think it's on the other slide, yeah, this disease is more chronic. And basically what you'll find is that the patient could have been in some stage of diabetes, of being diabetic, anywhere from 4 to 7 years prior to when they're diagnosed. They go into the family physician, you know, they do a blood test and realize that this patient has finally crossed the mark for being diabetic. Well, in my practice, I always go back 5 years as a general rule. I'll say, you know, Mrs. Jones, yes, you were diagnosed today, but you've been diabetic or some stage of being diabetic 5 years before. These patients, because they're chronic, we don't know when it started, so the need for care becomes more urgent. It is important that we get these patients care early. These are some of the ethnic backgrounds of patients who are at high risk: African American, Mexican American, Pacific Islanders, because of their eating habits, because of genetics. And if we had more time, you'll say, well, why is the Mexican American have a higher prevalence than maybe the European Spanish? There's a reason for all of that. But this is just to give you kind of a general overview of who these patients are and what we're dealing with, especially if you're working with patients. When you see these patients, you know that some of these patients have a higher risk of being diabetic. These are some other types of diabetes. You have gestational diabetes. These are patients who, after being diagnosed with gestational diabetes, have a high incidence of diabetes sometime in the next 10 years, 10 to 15 years. So these are patients that needs to be monitored. Surgically induced, like surgery on pancreas, we talk about chemically induced. Steroids are they're one of the most fascinating drugs, but they're also one of the hardest drugs on your body for many, many things, including if you're at risk for diabetes. Steroid treatment can tip the scale. Patients who are diabetic and are treated with steroids have to be monitored that much closer. And the other condition, LADA, is basically very infrequent. Now, prediabetes. There are patients who will think that being pre-diabetic is okay. And I always say that's like being pre-pregnant, you know. Okay, how can you be pre-pregnant without an outcome? Patients who are pre-diabetic are, in some sense, in denial. You know, I'm not really bad. I'm just pre-diabetic. And I always tell a patient who's pre-diabetic or hypoglycemic, you're heading down the road to diabetes. What we do now will help you to prolong that event, or you know, you'll get there earlier. It is not a safe place to be. These are some tests that we normally will do to help to diagnose pre-diabetic patients. And these many patients who are pre-diabetic we encourage them to exercise the same type of care, you know, the medication in your diet and your exercise, because that helps to prolong the event of being diabetic. These are some tests, and these are the results that basically shows you where the patient, and as a point of information, diabetes now is not diagnosed by your blood sugar, it's diagnosed by your A1C, which is the hemoglobin A1C, which is an average over 90 days of what your body does with sugar. As a general rule, there's a little bit of difference between the ADA and the Endocrinology Association, but as a general rule, I tell patients that if you're 6.5 to 7.0, which is this scale here, okay, you're in the safe zone. Once you pass over 7, it becomes critical. Now, that's not a hard and fast rule, because for children it's a little bit different, for older patients it's a little bit different. If a person comes down from 14 to 7.8, I'm happy, you know. So it is just a general rule. The other tests are there to help the physician try to determine if their treatment plans are working like they should. Now, the physician is one of the first persons who will come in contact with these patients, and what are they dealing with? You've got a patient, like I said earlier, who's pretty fragile, who's really anxious about what's going on. So the best thing that you can do is to conduct a thorough interview. Just to ask simple questions becomes very short-sighted, because like I said earlier, a lot of information, you have to dig for it. If you conduct a very thorough interview, you will find that there's a lot of information that you can get from these patients who at first will not actually sit there and volunteer it, but when they realize that you're not going to just take no for an answer, you need more explanation, they start to open up. Right, Sarah? You'll see that happening. They'll all of a sudden open up and they think, you know what? Okay, I'm being caught. I mean, and I'll tell you a quick example about this. It doesn't have to do with diabetes. A patient came in, she was taking these drops for glaucoma. I looked her in the eye and says, "Are you taking your drops?" "Yes, I'm taking them." Checked her pressures, are like 30. I said, then I pulled the instrument away. I said, "Now, are you taking your drops again?" And she hesitated. I knew she was lying. She finally admitted to taking it, to stop taking it. I said, "Why did you stop taking it?" She said, "Well, when I got the last bottle of drops, I decided I didn't need it." I said, "Now, wait a minute. People stop taking the drops when they're empty, when the bottle is finished. You went and got the bottle and then decide to stop taking it?" Her husband, who was there, she said, "Doc, that's what I've got to deal with every day." So sometimes you've got to be able to probe a little bit. You have to assess the knowledge of this patient, because a lot of times, you know, we tend to assume that they have some information. I always assume they have no information. You start from scratch, because you're starting from at least 0.0, you know. This way, you'll be able to design a plan that they can understand, that they're able to comprehend, they can put their arms around. You've got to assess the patient's involvement. If a patient is in denial, you've got a little bit more to work with, because you've got to let that patient know the seriousness of the condition so that they can start to take care of themselves, because like I said, you know, the provider cannot take care of themselves, take care of the patient. They can only advise the patient. The patient will have to take care of themselves. Some patients, especially the older ones, have a hard time following instructions, especially if you give them multiple instructions. They get them mixed up and they get them, you know. So you've got to be able to explain them in a sequential order so that patients can understand what needs to be done, especially if it has to be done in a certain order. You've got to let the patient understand that this is a lifelong condition and they're going to have to take care of it. It's not like a toothache or, you know, a cold. It comes and then it goes. It is something that will need attention here on out. You've got to be able to be available for the patients to ask questions. you've got to be able to arrange for these patients to talk to someone about their diet. In our practice, we try to give them some general instructions, but I'm not a dietitian, so we are in the process of getting a dietitian to visit our practice twice a month just to help these patients, because a lot of them don't have access to those, or the physicians, you know, you ask them, well, when last have you visited with a dietitian, and you get two look, the deer in the headlight look as if, what's a dietitian? Or they'll say, you know what, it's been 3 years. I always like the patient within 2 years to visit with a dietitian again, because let's face it, most patients will fall off the deep end, and we need to get them back on track. So we try to get them because your diet is important. We also explain the importance of exercise. Exercise is critical to these patients. They have to be involved in some type of exercise program. Now, you're going to get the patient who's in a wheelchair or who has bad limbs or bad hips or something. You know what? I always tell them, I never give them the excuse, well, you don't have to do it, because that's just like saying, okay, that's one less thing you have to do. I still try to encourage them to do something. And, you know, that's a whole different lecture we can talk about, is what you do for these patients. But you need to get them involved in some type of an exercise program, regardless of how little it may be. A lot of patients saying that I get my medicine and, you know, I don't have to go back. Or I only go back when the refills run out, okay? As a general rule, we encourage patients, and if it's not done, we'll do it for them. We do a blood workup for them twice a year. We'll never circumvent their primary care physician, because we'll send that to them if for some reason that, you know, it hasn't been done. But we encourage them to get it done twice a year. And that's to monitor things like liver functions, you know, and those types of things. A lot of times these patients who are diabetic are also on some type of high blood pressure medication or some cholesterol medication, which also has side effects as well. So very rarely are you going to see these patients on diabetes medication only. We try to make sure they get written instructions, because that way you've got to be able to provide them with something that helps them to be engaged, because if they don't know what they're getting engaged in, they can't do it. Translation services, it's a hard thing, because I don't speak Russian. So if someone comes in, I have no clue what they're telling the person. And that's always a challenge, but you do the best you can. You know, that's all you can do, is do the best you can. So now the physician is sitting there with this patient who they have to interrogate, and then who is basically sitting there totally scared about what's going on, okay? You've got to be able to change that. We have to be able to get these patients to feel, you know what, we're here to help them. We're not giving them a death sentence. I always tell patients that diabetes is not a death sentence. It is a death sentence if you don't take care of yourself, but if you take care of yourself, you can live happy lives, you know. And unfortunately, I always say that, you know, if you don't take care of it, they are very prominent people, and I use the Larry Miller story as an example. Here's a man who had everything at his disposal, but because he was negligent and didn't take care of it, you know, succumbed to the disease. So, you know, and everyone has heard that story. Now, why do we need to control diabetes? The reason is because these are some hallmark studies that were done that talks about just changing your A1C from 9 to 7%, what type of improvement you can get. In the DCCT, which is a big study that was done in the US here, they found that retinopathy, which is eye problems, broken blood vessels, leaking blood vessels, detached retinas, and those types of things, were decreased by 63%. As you go across the board, you see that it went all the way down to, in the United Kingdom study, there was a 21% reduction there. Nephropathy, which is kidney problems, you have a similar type of reduction in care, in improvement in the condition, in that the DCCT study was 54%. And neuropathy, which is neurological problems, similar results as well. Microvascular diseases are eye problems or strokes, you know. that's macrovascular disease, sorry, is the heart attacks, those types of large vessel diseases. We're still, we still have to let these patients know that diabetes is not just one entity here. It has other side effects that if you don't take care of it, it can affect those systems. If you take care of it, the risk of it affecting those systems are still minimal. They're still present, but minimal, okay? And this is the reason why we try to control the diabetes. Now, a lot of times, and I'll speak specifically on eye care for these patients. As we said earlier, type 1 is a more acute type disease, so those patients' need for eye care is not as urgent as the patients who are in type 2, which is more of a chronic type condition. As a general rule, and this varies a little bit, these are just very, very general recommendations, is that if the patient has no retinopathy or has just been diagnosed, annual exams are normal. Now, a lot of times patients say, well, oh, and no one is here, but we went through to some of the clinics and did the, no, you were at some of our clinics, and it's interesting. I asked the patients as we saw them, when last did you get your eyes checked? Well, 28% of these patients had an exam in the last year and a half, which meant 62% of them did not have an eye exam in the last year and a half plus. Of that group, about 8% of them never had an eye exam, okay? Now, a diabetic retinal exam includes, it has to be dilated. If it is not dilated, if the patient says, I went to, and I'm going to say Costco, and the eyes were not dilated, the chances are they did not have a diabetic eye exam. Now, not everyone who's dilated has a diabetic eye exam either, okay? So you have to quiz them a little bit more. Well, what did they do? And hopefully they'll remember, But the important thing is they have to be dilated, the macula has to be checked, and the back of the retina needs to be checked extensively. Certainly if they have retinopathy, the frequency of the visit will change based on the retinopathy and based on their A1C and based on their compliance and those types of things. Type 2, it's based on the severity of the retinopathy. A lot of times these are patients who have been chronically ill for 4 to 7 years, and basically, the truth is if they don't have any eye problems, they don't get it checked, Basically, they need to be informed that the eye examination is an integral part of the care. As a general rule, if you have diabetes for a long time and you're not controlled, you have a higher risk for retinopathy. Now, this is what I call a triad. We talk to patients about their medication, about their exercise, and about their diet. It's important to let them know that they need to let their providers know if there are any side effects from the medications. A lot of times, we all prescribe stuff. We never know. We can give 2 people the same prescription and both persons will respond differently, to let them know, The important thing that we tell them about medications is that if they're taking insulin, they need to be careful that their blood sugar is not low at night before they go to bed. The risk of going low at night, if you're low already before you go to bed, is pretty significant. In terms of exercise, we try to encourage them to get involved in something because they need to be involved in some type of exercise. Basically, as a general rule, we need 150 minutes of exercise a week. And the way I break that down is you have, if you decide to do 30 minutes a day, that means it's 5 days a week. If you decide to do an hour a day, it's 3 days a week. I never tell them what to do because I don't know what they like to do, but I tell them just do something. If nothing else, walk. 30 minutes basically means you walk 15 minutes one way, 15 minutes the other way. If you like to have a headphone with you, that's 5 songs one way, 5 songs the other way, And you break it down a little bit to them to make it very doable. Because if it's doable, they're going to try it, I had a guy the other day, he said, I don't do anything. I said, why? He said, because I'm thinking of killing myself. You know, sitting here thinking, okay. So it's important, you know. Diet is important, and we try to get them to a dietitian. Now, follow-up care is critical. I think in our current state of healthcare right now, this is one of the biggest challenges we have is that, you know, because the physicians are so inundated, it is hard to keep up with the follow-up visits. And it's basically to establish a monitoring system and to check the patient compliance, because that's how you know if the patient is, you'd be surprised, patients will look you in the eye, tell you, I'm doing everything you want me to do, doc, and they come back next time and you wonder what happened between then and when they come back, because they totally screw up the whole process. You know, you want to look and see if, you don't want to see if your treatment plan is working. You know, if it's working, great. If it's not, then you modify it. You want to get the patient engaged, because if I know I'm coming back to you, okay, how many of you brush your teeth before you go to the dentist? How many of you floss before you go to the dentist? How many of you floss the day before you go to the dentist? See? And you'd be surprised how many people do that. And you ask them, well, what did you do before? You know, we see that with patients who use eye drops. Oh, well, I haven't used it last week, but you know what? I used it today. Why did you use it today? Well, I know I was going to come see you, you know. So you want to get them engaged in their disease, because the more they're engaged, the greater the success you're likely to have. We're all involved in this. We are all participants in helping these patients to get better, to get involved in their condition, and to make sure they stay healthy. We need to be, you know, the PCP needs to be a source of information. The eye care, the dental, the foot care people need to be involved. They need to talk to them about it, because if the more you hear from different providers, the more likely you are to do the things that you're supposed to do. Unfortunately, that doesn't always happen. Dietitians need to help them to achieve their goals. Social workers need to help them with their, you know, with their emotional situation, and be able to help them to get through some of these tough times when they're doing everything they can. They check their blood sugar and it's 7, you know, it's 170 or 200, and they're doing everything they can. Or the patient who might not be, you know, don't understand what they're doing and are so frustrated. So what do we expect from this? This is the ultimate goal is to help these patients to get better. We need to have them recognize their condition and take care of it. We need to make sure that the team tries to help them to achieve their goal, and their goal is to be stable and within those guidelines that are set as being normal. We need to make sure these patients don't have to worry about losing their sight or their limbs, to make sure that, you know what, we can do things to help you if you help yourself, because we cannot do it for them. And we need to get these patients to engage in their total care, because that's how we were able to help them to control it. Now, am I okay?
You are.
Good.
You have about 8 minutes.
Okay. Now, this is the part where I'll be happy to answer any questions or clarification or anything of that nature. Okay, Heidi?
I just wanted to go back to your example. So what did you do with the patient who's suicidal?
You know what? I sat with that patient and talked to that patient, and by the time I was through, one, he was smiling. He committed to get on an exercise program, and he told me he will start going out to the senior center. His world was closing in on him. His wife was at work every day. He had nothing to do. He was retired. He was bored. He was overweight. His blood sugar was out of control, you know. And I tried to show him what he needs to do to expand his world again, you know. He said he's going to go down to the Senior Citizen Center. He said he's going to go to the rec center. And he told me he's not going to kill himself again. Sarah?
Well, I just want to comment. So, as you guys know, this gentleman is an eye doctor, and this is an atypical commitment to behavioral change with diabetes patients from my experience. So I just want to commend the breadth of what you take on. And in my practice, we do the retinal camera. So I'm working in low-income practice, and we screen patients Masihdas. And one of the things we know is that connecting people with diabetes to disease in their eyes, and diabetes is #1 cause of blindness in Utah and the U.S., connecting the importance of your sight with your condition makes a huge impact. So I just want to comment that I thank you for taking on that commitment when you're discussing people's eyes, because it's a special window into engagement and interest. And not all providers of eye care take that step and partner with primary care to say, this is a moment when I can actually talk to them in a new way about their commitment to their health and what's important. And nobody would argue that sight is not important. And so, again, it's a unique practice. And it's like a dream for doctors like me that every person who engages a patient with diabetes engages them with what's important to them related to what you're caring about. And that eyes are super important. So I just want to comment.
Thank you. You know, we have, oh, go ahead. Yeah. We have a system set up whereby we go through, when a diabetic patient first comes in, we go through a whole series of education and testing to get baseline information. And we have a lot of colors on our results, so we show these patients good, bad, indifferent. And I found that it's engaged the patient significantly because they're seeing something. They can see improvement. They can see when it doesn't get better. So it's what we do. Go ahead.
I was going to ask you about your health literacy. You know, retinopathy is sort of a complex disease, and possibly a majority of your patients, you know, have low health literacy. If they're low income, there's a correlation. How do you overcome that?
You know, it depends on the patient. A lot of them, we try to, you know, you can sit up here and explain it in all the technical medical knowledge, and it goes straight over their head. You try to explain it to the level of understanding. And I don't talk about retinopathy, I talk about bleeding. I don't talk about, you know, A1C, I talk about sugar. And then as they get more involved in this, then we move up. The next visits, we start talking about some of the more technical stuff that, you know, that's important. So pretty soon, they start to grasp the concept, you know, and that's all we can ask them to do, is to grasp the concept that this thing happens and we need to take care of it, you know. And, you know, what Sarah said is true, because a lot of times you go to your family doctor and, you know, you always think, oh, all I'm going to get is bad news. Well, you come to the eye doctor, you don't expect bad news. So I have a window of opportunity there to help these patients at a little bit less stress level for them. They're a little bit more amenable to listen. They've heard a few things before, and then we just add to that. So I'm in a little bit of a unique situation that, you know, I'm never going to tell them they're going to die. I'm never going to tell them that, you know, any bad things. But I still tell them what hopefully their primary care physician tells them. Any other questions? Go ahead.
Yeah, it's not really a question, more of a comment, but tying things back with our discussion yesterday, perhaps more discussion later today. But you talk about the difficulty in eliciting information about, you know, whether the patient is taking their drops. That sort of information is difficult to get, and I'm sure. But something like someone who went to Costco to have their eye exam done, unfortunately, that's the kind of thing or unfortunately, that is the kind of thing that could be captured with health information technology. Information exchange kind of scenario where that sort of information should be available, should be capturable. And if it were, it would make your practice that much easier to know for sure this is what this patient had done, this is exactly what they had done, and this is what the outcome was.
What they're supposed to do and what they do sometimes it's not always the same. You may get the report back, you know, we're part of the chain, we can get the information from their doctor. Oh, this is what you're supposed to do. Oh, have you been doing that? Well, no, you know. So your point is well taken. In an ideal world, yes, having that information will be good. Sometimes, you know, you work with people and you don't know what the heck you're going to get sometimes, you know. You would like to get the correct information. You would like to know that when I tell you do 1, 2, and 3, you do 1, 2, and 3, not 1, 3, and 2, you know. So, did you have a question? Anyone else? How am I doing? I invite anyone, if you want to stop by our clinic sometime, you're welcome to do so. But thanks for this opportunity. Here's my information. As Heidi said, this is going to be on some publicly
Website,
accessible.
probably too.
Yeah. So, well, thanks very much for your time, and I hope this has helped.